So next is some very kind psychologists from the Walton Centre. We've got Chrissy and Jane, who are doctors of psychology from the Walton Centre, and they are experts on functional neurological disorders. And I hope that they are here now, and Chrissy could come on the screen and start our talk on functional neurological disorders. I think I can see her there. Chrissy?
Hi, hello. I'm not a psychologist, just as a disclaimer.
Oh, sorry.
I'm a neurologist. Have you got my slides? Because I'm on my phone. I'm just in a clinic, so I was told that I wasn't going to be controlling my slides. Sure. I think Jane can if you can't.
Yeah, I think Lorraine, are you there? Have you got the slides that you could share on the screen, please?
Thank you.
So you're a neurologist, sorry.
Yes.
Okay, great. And Jane is a psychologist.
Yeah, she's a consultant neuropsychologist.
Lovely.
Brilliant, thank you. So is it Lorraine who's controlling these slides? So so that's just the title. If you go to the first slide, that would be brilliant. Yeah. Okay, so we're going to talk briefly about what functional neurological disorder is, and I think certainly in my head, functional neurological disorder is when you make a diagnosis and give that label to a patient, but there are lots of other patients who don't have the diagnosis who have functional neurological symptoms, many of whom I think are seen in the pain setting. So the word functional was used because it is a problem with the functioning of the nervous system. So instead of a structural problem like a stroke or Parkinson's or a degeneration of one of the systems, everything looks normal, but obviously isn't functioning normally. So patients are struggling with various symptoms. And so because of that, it's not tied to any particular part of the system. So people can have any symptom, basically. The most common symptoms that we see are blackouts or loss of awareness, which are dissociative events or functional seizures, or weakness, which can affect one side of the body and mimic a stroke, or it can affect both legs or one leg or one arm. And movement disorders, so a lot of people have involuntary movements, which can be jerks or tics or anything really. But we also see the whole spectrum. So you see people who can't see, who can't speak, who feel very dizzy all the time. And I'll sort of mention a little bit, but also a lot of these patients have brain fog, which is very common in fibromyalgia and some of the pain syndromes. People will say they can't concentrate. And up to 80% of patients have pain of one type or another, most commonly headache, but also fibromyalgia and other pain problems. Can you do the slide, please? So the terminology. So I think this is important because what happens in the NHS, because of training and this not being something that people were taught about if they graduated when I did, is that people use different terminology and that confuses patients. I think, sort of the Freudian view and maybe the last century view, if you will, is the psychological explanation. So, you haven't got anything physically wrong with you, you've got something psychologically wrong with you, and that's why you've got these symptoms. And I think we've moved on from that some time ago, but many people haven't, and that's just because they were trained with this kind of model. But we know now that 30% of patients with functional symptoms will not have a psychological cause that we can identify, and that's really important. So when you're explaining and talking to patients, if you are, if you yourself as a clinician are tethered to this idea it's psychological, you'll lose 30 people because it will make no sense to them, because there won't be anything psychological that you can find to explain their symptoms. And so now we've certainly moved away from that. So for the diagnosis, it's no longer necessary that there's been a trauma or a psychological problem before these symptoms develop. And so we've moved away from that. So psychogenic, people don't like that. They just hear the word psycho. Conversion was, again, very Freudian, and it makes sense for some patients, but there's a lot of patients who don't fit that model. So we've moved away from that. And then the other thing that you hear a lot is the sort of negative things. So this non-epileptic attack, you've got non-organic symptoms. And again, that's not helpful for patients because, you can imagine, so if I develop a weakness in my leg, I can't walk, it worsens and worsens, then it involves my other legs, then I end up in a wheelchair. I see a load of doctors, I have lots of tests, and then they go, oh, it's all right, you've got a non-organic problem. It just sounds like you're being fobbed off. And I think the same with epilepsy. You go home from clinic, you're having 20 blackouts a day, you're shaking, you're injuring yourself, and you're told it's non-epileptic. I just don't think that's an acceptable explanation, really. And people, again, think, okay, well, that's fine, it's not epilepsy or it's not a stroke, but what is wrong with me, because I'm really disabled by my symptoms. So I think we need to move away from that, and we have within the field. And then medically unexplained, this MUS thing that is still popular. Again, what does that say? It says it's medically unexplained. So it says that the doctors looking after you don't know what's wrong with you, and it hardly inspires confidence, which is why we left, and none of the terms are perfect, we're left with functional, which at least you can explain it as a mechanism. So you have a functional problem. Obviously, things aren't functioning properly. These are real symptoms, but it's a functional issue rather than a structural one. And dissociative for the seizures is useful, because dissociation is what's happening for most patients. And again, it makes sense. And I think people just want to know what's wrong with them. Next slide, please. I'm on my phone, so these slides are so small I can barely see them. I think this was just really to say that functional symptoms are common in neurology, but they're common throughout medicine. And for patients with chronic pain, you know, we can tick a lot of these boxes quite often, I think. So, you know, in my clinics, lots of people have IBS. Many of them will have been investigated for palpitations or chest tightness or, you know, breathing problems. Lots of people have unexplained aches and pains in joints without finding any structural pathology. And so there is a sort of system presentation of this, of somatic symptoms, which we see across the board. Slide, please. Sorry, I can't even see this one. Yes, and just this would just say how common it is, really. So in neurology clinics, the most common presentation is headache. Second most common is functional symptoms. Lots of people have looked at this, and the figures vary. But locally in our audits, we found between 10 and 16% of patients will have a diagnosis of functional symptoms, which of course there will be an additional group who aren't diagnosed or who have MS or epilepsy, but in addition might have some functional symptoms. And it's as common as MS, at least. You know, this is something that in seizure clinics, at every clinic you'll see somebody who has functional seizures. You know, a quarter of people who come in for inpatient telemetry investigation have got functional seizures. So it's a common problem. So I think the NHS is a bit behind in terms of treatments and clinics for these patients when they are patients who we're seeing and have been seeing for decades commonly. Slide, please. So this is just, if you want to click the hyperlink, I don't know how well this will work over a sort of remote meeting. So if it doesn't work, we can abandon it. I want to click that link and see if it will play. This, if it doesn't play, it's okay. So this is just an example, really. So functional symptoms are all over the media. So if you look for them, which a group of us in the UK are doing, you see it everywhere. So this is a cheerleader in America. She had a flu vaccination. So I think it's topical because we've had a lot of functional presentations flaring up after COVID vaccination recently. I couldn't find a good enough video, but she basically, if we could get this to play by clicking the link, you see that she's got a very functional pattern of gait. So she walks in a very sort of labour intensive way. So she walks with her legs flexed. You can see she's stooped over. She walks very slowly and very difficult, or with great difficulty, I should say. And she has a functional gait disorder. I think any neurologist can look at the video and just make the diagnosis. There's absolutely nothing else it could be. There is no structural problem in the nervous system that could make her walk in the way she does. And yet these cases reach the media. So she's all over the American media as somebody, as a young cheerleader given a flu jab, and then, you know, her whole life's destroyed by this terrible neurological illness. And it's a functional illness, and it's obvious, and what she needs is obvious, but people don't make the diagnosis. And I think all of us in the NHS see these patients, and so raising awareness is really important. Do you want to move on from that then? That's Desiree, I think her name is. Should we go to the next slide? Thank you. Yeah, so who gets FND and why? So basically anybody can get FND. This sort of stereotype again in Freudian days was it's young hysterical women, but it isn't. It's people of any age. It's more common in young adults, but children have it. There are people as young as 4 with functional symptoms. I've seen people in their 80s present with functional symptoms. It's male and female, probably more female, but about, I think, a quarter to a third of our patients are male. And it's multifactorial, so it's unusual for someone to have one event that then causes the development of their functional symptoms. And of course that can happen, but we believe that there's a multifactorial background of susceptibility, if you like, and then there'll be a trigger sometimes that can set off the symptoms. And I'll talk about that a tiny bit more in a minute. If you want to move on to the next slide, I think that might be more helpful. Thank you. Oh, and this was really helpful. This is a while ago, and there's a charity called FND Hope, which was set up by a patient with functional symptoms years ago now. He was very frustrated. Sorry, can we go? Yeah, thank you. Very frustrated just by the lack of understanding and the lack of research. And this was literally just a patient poll about what triggered your functional symptoms. And you can see at the top there, if it can sit still long enough, you've got physical illness, you've got people having operations, you've got infection, you've got vaccination actually is up there. So it's almost anything that can upset the system. So I've had people who've been in just for an appendicectomy, but then never been able to move their legs again. There are people who, of course, have had psychological trauma. So I have people who've been, mugged, or they've lost somebody who's important to them. So anything that destabilizes you, it can just be like the final straw, I think, and triggers it. But about 2/3 of patients will tell you that there's something triggered their symptoms, and that's often a physical thing. A little bit again like chronic pain, especially regional pain. It can be a fractured arm, and then you can never move your arm again. It can be, back pain, and then they can't move their legs again. And I think part of that is psychological. So if you present with possible cauda equina with severe back pain, and you can't, you're in a re-retention, you're very scared, and it's the whole thing's traumatic. You have your scan, and then of course you're told by the surgeon there's nothing wrong with you, but you still can't move your legs. And so, although the physical aspect of pain is there, you also have a big psychological element to the presentation and the trigger. And so we know that attention is really important in functional symptoms. We know that focused attention on the physical problem actually exacerbates it, not through any fault of anyone's. It's natural. So if I couldn't move my leg, I'd be much more conscious of what my leg's doing, which would make it harder for me to work. And a lot of the sort of physiotherapy approach is about attention, really, and the way that you look at your walking, rather than, if you have a stroke, you'd really be focusing on that right side. You almost have to not look at it at all, or use a mirror, or use different ways. People have used VR to try and get rid of that sort of blocked pathway between your brain and your motor control. And external beliefs, of course, can have a big impact. So we see quite a lot of patients who believe they have a physical illness that's causing their symptoms, because their symptoms are physical and they can't really move from that, and that can be a perpetuating factor. Do you want to go to the next slide? Thank you. So this is just some potential risk factors, and as you can see, this is really quite broad. So anything that's difficult, anything that's upset the system. We know that early life experiences can make you more likely to develop functional symptoms, but it's not just early life trauma or abuse, it's also neglect, or just learning not to express your emotions, the way your parents treated you. Under my care, who had an ill sibling, for example, when they were growing up, so they learn to internalize their own feelings and not complain about how they were feeling, because it seemed so minimal, compared to what their sister. So the patient I'm thinking of, her sister had a tumor behind her eye, so she had to go for surgery a lot of times, and her mum was always trying to hold it together for the sister. So my patient, as a sibling in that sort of dynamic, felt she could never talk about how she felt, and it just would seem very selfish to complain about how she was feeling because her sister was having such a tough time. So, if you think about that just as a formulation, that patient had a sister who could have died on many occasions, and that must have been traumatic for her. She had parents who were very diverted towards that sister, understandably, which will have had an effect on her. And also she felt she couldn't express her own emotions, and she was selfish to do so. So she's grown up as somebody who just never moans about anything, never tells anyone she's struggling, and that can be a predisposing factor. And there are lots of things that can be, but a lot of it's environmental, some of it's probably hardwired and genetic, although we don't have any genetic information about FND as yet. And then you have your triggers, so your precipitating factors. So we've talked about those really, and they can be psychological or physical. And for about a third of people, we don't really know why it happens when it does. And a lot of people will have had trauma for years and years and years, and actually be sort of in a safe place for the first time, quite relaxed when they begin to have their functional symptoms. And I think of that almost as though your brain keeps you going when it has to, and then when you let your guard down, sometimes some of these things leak out. And then we have perpetuating factors, and lots of those are the frustrations of not knowing what's wrong with you, the long journey, which hopefully is improving through navigating the healthcare system, long waits to see people, not seeing people who say something different every time, and lots of other factors like pain. So chronic pain can really be a perpetuating factor, because if people are in pain and they can't sleep and they're struggling, then they're more likely to have functional symptoms. And if they've got the functional symptoms, and having jerks or seizures, which exacerbate the pain, it becomes like a vicious circle. Should we go to the next slide? And this is the same thing, put in a different way. I just like this. This is the Brown and Roiber model. I just think it's a nice visual model of how you have, risk factors, and then you have a trigger, and then you have perpetuating factors, and those arrows are the vicious cycle that people get into with their functional symptoms. And I think, studies showed a few years ago, studies showed that if you had seizures, for example, the average was 7.2 years before you were diagnosed as having functional seizures, which obviously isn't good for anybody. I suspect we've got that much lower now. More recent papers are sort of 3 years, 2 years, but that's still not very good. And you think what's happening to that person within that time, and all the family around them are anxious, and that's the perpetuating cycle. Go to the next slide, please. So making the diagnosis. So, the really important thing, I think, is that this is not a diagnosis of exclusion. And certainly within neurology, we get referred these patients, and patients go away with the idea that, and they tell us this regularly, I'm sure Jane will say the same. So we hear from patients, oh yes, I went to see him about possible MS. I had loads of tests and they said it wasn't MS, and they just discharged me. And that's not what this is. So if I go to the waiting room to bring in a patient and he has a functional gait, like the lady who we couldn't see on the video, I know he's got a functional gait disorder. I know he has a functional problem. He comes in, he tells me his story, I examine him, and I'm pretty sure by then, just like with any other medical condition, just like if he had Parkinson's, I'd have known as I watched him walk in. And I think we need to move to just being honest with people and saying, do you know what, I think you've got a functional problem. This is what it is. I might, if I feel I need to, I might do this test just to make sure you haven't got, whatever it is I'm looking for. But really, this is probably what it's going to be. So I'll do the test and I'll see you again. And I think if you frame it like that to patients, they're expecting it, and it helps them because it moves them along, and it gives them the sort of certainty they need about a diagnosis. Whereas certainly the tradition in neurology, and I think in other walks of medicine as well, I see lots of people with urological or gastro symptoms, and it's the same. They have a load of tests, but all the doctor really explains to them properly is that you don't have X, Y, or Z. And we need to turn that around. This is a diagnosis we can make clinically, just like we make lots of other things, lots of other diagnoses. Can we go to the next slide, please? Yeah, so communicating it. So these are just some things that patients come away with, and these are things, if you go back one, these are things that patients have said to us. So, they've got no idea what's wrong with me. They've told me I've not got MS, but I don't believe them because I can't walk. They said I've not got epilepsy, but my next door neighbour is a nurse and she said I've definitely got epilepsy. So I can't see the slide, sorry for those other quotes. If you go back to the previous slide, communicating the diagnosis. But I think it's really important because quite often these patients are discharged. So they see a specialist who says, you've not got a problem, it's within my remit, so I'm discharging you. So all these things that patients say to us, other people don't hear, but I think it's really important to just be aware of how we speak to patients in a consultation has a massive impact on them, because they do remember these are key moments for them, even though it's just part of our daily work for us. And that thing about functional symptoms can happen when you're relaxed. It's not that somebody upsets you and then you have one. They can happen at any time. And I think people find that really hard to understand. So communicating it's really about us understanding it, so we communicate it well, and then you do it in whichever way works for you. Sorry, can we go to the next slide, please? This is my last couple of slides now. So I can't read it. Yeah, so so this is the thing that patients really struggle with. I'm in a wheelchair, or I'm having 50 seizures a day. I've not been able to go out, I've lost my job, I can't drive, my mum now lives with me, I can't even go to the toilet on my own. How can it be nothing structural? How can it not be a disease? And also, how can it not be something that you can do an operation or give me drugs for? And people really struggle with that. And I think there is a big overlap with pain here. So it's again, how can I be in so much pain, but you're telling me it's all okay? And they might have had an MRI of their lumbar spine, which shows a little bit of degenerative change, which everybody over 30 has. But then patients become very fixated. It must be that thing on my scan that's causing this, because it doesn't make sense to people to be so physically disabled by symptoms that we're saying aren't physical. And I think that's where it's really important to have psychology, which I'm about to pass over to Jane, but to help people to understand, if you're embarrassed, you go red. If you've got an exam, you might have diarrhea or a sore stomach. If you're really upset or really, really worried about something, you might have chest tightness or feel like you can't breathe, and they're all normal physiological symptoms. And this is just to sort of amplified version of that, I suppose, if you like. And yeah, there's an overlap, as I think I've mentioned, with pain. So yeah, these are very useful resources. So these are the two websites that we most commonly give to patients, and I've just shown you a screenshot of those there. The Neurosymptoms is brilliant, and it has a section on pain. FND Hope, the charity, has a section on pain, and they talk about chronic regional pain, they talk about fibromyalgia, because there is a big overlap. And I think there are a lot of commonalities in terms of the, you know, the need for an MGT approach and the way that we explore and explain the symptoms. Can we go? I think this might be my last slide now coming up. So this is the cheerleader who we can't see, and what this clip shows is that she eventually, having been terribly disabled, and she was walking in this terribly difficult way with her legs bent forwards, but she could walk normally backwards. And so there's a nice scene where the interviewer's got his microphone, he's jogging backwards next to her, and she's jogging along normally, but then as she tries to go forward, she just collapses. This shows that, you know, 2 years later, after being on telly a lot in America, she's met a neurologist, and I use that word in the loosest possible way, with his white coat on in California, who's given her some intravenous, God knows what, you know, monoclonal antibody treatment, which has cured her rare neurological disease. And so it shows her running a marathon, but then she still has slightly slurred speech after it and things. And so she's been given this completely erroneous and fraudulent, I'd say, you know, explanation. She's paid privately to see this guy who's treated her for her terrible flu jab reaction, which is all over the Fox News and things in America. And if you think of the effect that would have on public health and putting people off vaccines, you know, you'd be terrified, wouldn't you? If you're in your 20s, you wouldn't want to have a vaccine in case this happens to you. And again, just to really stress the importance of us naming what it is. This is a functional problem. It's a common problem, and we need to treat it appropriately. I think that was my last slide. And I'm going to hand over to Jane.
Hi, I'm Jane Martlew, and I'm consultant neuropsychologist at the Martlew Centre. So thank you, Chrissy. I'm going to continue and talk about the treatment of functional disorders. Lorraine, are you going to put my slides up for me? Great. That's brilliant. If you could just go on to the next slide, please, that'd be great. Thank you. So just quickly, that's what I'm going to cover. I think I've got to finish by 10:40, so I'll whiz through this as quickly as I can to make sure I finish on time. So yes, these are the things I'm going to cover. I'm going to touch on chronic pain and FND and functional movement disorder as well, but bear in mind that I'm not an expert on chronic pain, and I took advice from an expert in order to ensure that I had my information correct about that. I'm going to, as I say, talk about some treatment and some strategies that you can use with clients. I'm also going to touch on some of my slides overlap with some of the things that Chrissy's talked about, so I'll skim past those. Next slide, please. So as Dr. Burness mentioned, there's lots of reasons why this particular condition, whichever guise it takes, it can be very difficult to treat, but it isn't impossible to treat. But these are some of the issues that people might bring to the sessions that make it really quite difficult to work with them, and can be difficult when you're actually trying to assess those people in clinic in the first instance. One of the most recent ones is one I added right at the end of this slide, which is a new one on me, whereas a patient who did have chronic pain as well as functional disorder started taking Oromorph during therapy, which of course was, apart from being inappropriate, made it impossible to actually do any work with her within a short space of time, because she was, well, the Oromorph was taking effect. So there's a whole host of reasons why this can be a very difficult condition to work with, but it's not impossible, and we do have some good outcomes, and there is some good research out there that shows that these people can see significant improvement. Next slide, please. Yes, so just to give props to Dr. Kerry Matthews, Consultant Clinical Psychologist for Liverpool PMP and Pain Rehab Service Lead. She was the expert I consulted in order to just make sure I had my information correct. So in terms of the functional overlap between the two types of services that we provide, there's a lot of similarity with regard to importance of using appropriate language within this patient group. The difference, which I found fascinating, which I hadn't realised, was that we use different terminology to talk to these patients in our two different situations. So in the functional pathway we use, we talk about functional disorder. We try to explain it in a very as straightforward a way as we can, as Dr. Burness explained. In the pain side of things, the chronic pain side of things, when you're talking about doing some rehabilitation, there's a slightly different emphasis on it, and I'll be coming to that in another slide. But the reason for the different emphasis is that the pain, saying that it's functional, can actually damage the ability for the person to engage in that process, because they can have been on such a long journey anyway, feel invalidated, feel like nobody believes them anyway, because you can't see pain, as you know. So using the appropriate terminology can really be a bridge to that person engaging in therapy or rehabilitation, and actually making some significant changes. Interestingly, Dr. Matthews said that only a tiny proportion of Liverpool PMP patients would fit the DSM criteria for FMD, which is another reason why they don't tend to use the functional terminology when they're working with their patients. Next slide, please. Physiotherapy is really important. We have a lot of patients come through our doors who have functional movement disorder. We are extremely lucky in that we have a very good physiotherapist called Michael Walsh, who was trained by Glenn Nielsen, who I don't know if I'm hoping you will have seen some of his research about doing treatment with people with functional motor disorder, functional movement disorder, particularly relating to gait and walking disorders. And he's had some tremendous results. I watched a presentation he gave, and some of the video footage of before and after was just astonishing. And we're fortunate to have one of his trainees with us, so we're extremely honoured to have him with us, and hopefully he will continue to be with us as well. So it's well worth looking. If you're not familiar with it, it's definitely well worth looking at Glenn Nielsen's research in neurological physiotherapy in functional movement disorder or functional motor disorder. Next slide, please. Just keep an eye on the time. Where are we? Time. Yeah, so these are just a few things just to, in case you aren't familiar with it, a couple of references for Glenn Nielsen and the Physio for FMD trial, where this treatment came from, and we were part of that, that trial process. Next slide, please. Yeah, so the approach to working with pain in the context of FMD, there are helpful things and unhelpful things, and rather than have a whole list of things, which we've only got a small presentation here, a short period of time, so what I just put down was just a couple of little things that might be helpful. So it isn't helpful, as I said before, to say that just say the pain is functional, or to say it's medically unexplained. I'm sure none of you would do that anyway, but some people unfortunately do. And we have, I've already mentioned why that can be unhelpful. It can break that ability for that patient to then engage with the process of any kind of intervention, if you're saying basically it's all in their head. Instead, it can be more helpful to talk about the fact that they have chronic pain, and they also have these other symptoms as a result of the chronic pain, or that they cause the chronic pain, or however you want to describe it. But you do need to mention the psychological side, of course, and then you can talk about that being associated emotional and psychological distress and or panic attacks or that kind of thing. So the focus is acknowledgement, it's validation of what the patient is experiencing, and actually saying you have chronic pain. So they feel validated, they feel understood, they feel listened to, and any other symptoms that they have, but they also have associated emotional and psychological distress or panic attacks, and that's true. As you know, chronic pain causes incredible emotional and psychological distress for people, and restricts a lot of their activities and their social lives. And if we can get them to engage in therapy, then anything that's going to help that is going to be extremely valuable. So using terminology that facilitates that process into rehabilitation is very, very worthwhile. Next slide, please. Yeah, so I think I've just covered this, haven't I? About the validation and empathy. Yeah, so they're just similar kinds of things. And what we're leading into is a slow phase rehab combined with psychoeducation, where you're addressing that anxiety about what happens if I walk on this leg or this foot? What happens if I feel pain? That means I'm damaging something. And that's an understandable fear, and you're helping to address that person's fear through expert understanding and knowledge and education, physiotherapy, all of those kind of things combine in a good pain management program to help the patient address that fear and anxiety and work with them to move forward and to increase their activities of daily living, increase their ability to engage in a social life as well, and improve their quality of life overall. Next slide, please. I know I'm whizzing through this, but I'm also aware of the time, so I'm desperately trying to finish on time. Okay.
Jane, don't worry too much about the time. I think you're doing a really lovely talk, so just carry on. Sorry.
Okay, thank you. So the Liverpool PMP, which a lot of you will be familiar with, functional seizures, for example, or other functional symptoms are not an exclusion criteria at Liverpool PMP. Oh, I've put PNP, excuse me. But that is not the case in all PMPs. Some PMPs will not accept functional patients with functional symptoms, but they will work safely with those patients in groups. If not in a group, it might be in a one-to-one situation, because otherwise they'd be in corridors and in the gym and things like that, and it wouldn't be safe if they have drop attacks and things like that. They don't work with trauma, they don't work with any particular FND symptoms. That's not the focus. The focus is on pain, but they work on a management plan with patients for managing symptoms during the course, and that is how they deal with the functional side of things. That's sort of slightly to one side while they focus on the pain aspect. My interest in that interface between those two things is, okay, how much impact would that have still on the functional symptoms, because you're actually facilitating them to move through some of this pain that may be triggering those functional symptoms. So I when I was having the conversation with Dr. Matthews, I was really fascinated by this interface that I'd never really thought about before, because we're two separate services. So I'm going to be looking a little bit more into that. Next slide, please. Yeah, so treatment of functional disorders obviously depends on etiology and predisposing factors and presentation, etc. Move on to the next slide, because we've got other more important stuff, and that's Dr. Burness has already mentioned that. I think one of the things that does get forgotten sometimes, and I will repeat this because Dr. Burness has already mentioned it, is that diagnosis is key. Actually giving a clear diagnosis in a way that makes sense to the patient and helps them to understand. And sometimes that John Stone website that Dr. Burness gave the information about, that can be so helpful, but for patients to go through and then come back to and look at again at another time. Education about FND is part of the treatment process. It has to be. They have to understand about how their condition developed, or how their condition progresses, or how their condition affects their lives, and how they can make changes. They need to feel a sense of agency that they can actually make a change in their lives, and that they can change their symptoms. And it's not an easy thing to do, but it can be done, and it is done on a daily basis in a lot of services. Well, the few services that provide this kind of intervention. With motor symptoms, physiotherapy alone or with psychotherapy, it depends on the patient and the situation. We're lucky in that we've got a physiotherapist. John or Lorraine, just shut me up whenever you need to, okay? Because I know people will want coffee, so just shut me up. Next slide, please. I won't go on this because Dr. Burness already mentioned it. Just one thing I will say is these predisposing factors and precipitating factors, especially the predisposing ones, they are risk factors, but they are not causes. And that's something that Christy touched on. But the fact is that people sometimes make an assumption that because somebody's got a background history that includes abuse, therefore that is the cause. And that is not always the case. And I think people feel sometimes invalidated by the fact that just because they've had something happen to them in their background history, people then assume everything is related to that, and they become very disengaged from medical services because they don't trust the medics to actually look at what the cause might be, because they're convinced that all they're doing is looking at the history part of it. So it's important to I just wanted to mention that again. Okay, next slide, please. Lots of different approaches can be used, and that includes things like CBT. Laura Goldstein and her group have done a lot of work looking at randomized controlled trials, working with CBT for people with functional seizures, and got some really good outcomes. There's a good evidence base that EMDR, people who do have trauma work to be done, it can be extremely helpful, and that's with patients with functional disorders as well. There's also things like the less well-known sensory motor approaches, which is where you look at that mind-body interface, which is often not well understood by the patients. There tends to be a bit of a disconnect between the mind and the body, and if you can get that working together, then you can actually move things forward quite a bit. And more well-known things perhaps like compassion-focused therapy and that kind of approach. There's lots of different approaches. We are doing a Cochrane review at the moment, updating a Cochrane review. So hopefully there will be a good summary of evidence available at some point if it ever gets finished, but we're working on it. Next slide, please. I'm going to jump through this because we've run out of time. I'm very aware of that. And just saying that there are different phases to actually doing therapy. This is probably more important for if there were therapists in the audience, but I don't think there are. So we'll just move on to the next slide, please. And just say that these are the kind of skills, that the kind of work that we would do in a session, and we would try to increase, for example, interpersonal skills, and the reasons why would be to decrease those interpersonal difficulties and fears of abandonment, etc., etc. So we look at, this is where your formulation comes in, your understanding of what the precipitating factors are, what the triggers are, what the things are for that person in their life, what their difficulties are, what skills are we going to build up, and how are we going to approach that. Next slide, please. And then we've got some very basic strategies around trying to get rid of some of the tension, some of the panic that people can have, how to calm them, how to get them moving if they're hypo-aroused rather than hyper-aroused, etc. Next slide, please. Psychoeducation, I've already touched on, but the importance of the window of tolerance model I will come back to in just a minute. So let's just move on to the next slide, please. And the next slide, please. So stabilization, the previous slide was a quote, but it's basically saying that without stabilization, you are working in an unsafe way with patients, especially patients who have traumatic background histories. And we do, in fairness, see a lot of people who have trauma in their background history, but we're very aware that that is not diagnostic. We don't treat it as such. So there's lots of techniques that you can work on with a patient to actually make them feel like they're in a safe haven, like they're in a safe place to work, and it's a safe place to try things out and to experiment and to talk about things. And that safe space is critical for patients to be able to be open and work on some of the difficult things they have to do in therapy. Next slide, please. That's the window of tolerance model. That central section is the optimum window, where that's the safe space we want people to be in. If they get over aroused, they become very tense, hypervigilant, very emotionally volatile. It can trigger a kind of excessive symptoms, etc. And then hypoarousal, you just can't get anything out of them. They feel flat, unable to engage. So the grounding techniques, all the stabilization stuff is to try and get them into that window of tolerance. Next slide, please. And these are some of the resources that we've developed in the Walton Centre. It's just a sample of some of the things that we've developed for the service. So we've got leaflets about dissociative non-epileptic seizures, about functional motor disorder. We've got a booklet that explains about how the patient can try different things to take control of their own functional symptoms. And some of them are very straightforward, things like breathing skills and trying out some mindfulness, doing some sensory grounding. We've also, our wonderful therapist, Helen Bouchard, has done some audio files, mindfulness audio files to help patients who have got particular issues or particular things that they want to work on, to actually give them those files so that they can practice them at home. So she's actually, this is just a start. She's developing a great resource for us, which we really appreciate. Next slide, please. Nearly there now, I promise. I'm not going to go through the processing of trauma, but I think these slides are going to be shared around anyway, so the information will be there. Next slide, please. And this is the part that gets left out sometimes, the reintegration and reconnection after the treatment is sort of finished. It actually isn't. You need to do the next step, but unfortunately with the NHS the way it is, and time, not being at a premium, you can't get to this phase, and this bit normally has to be done by the patient on their own at home. Next slide, please. Yeah, so again, this is part of that phase. Sorry. Next slide, please. So overall, good explanation of the diagnosis is critical. Practical psychoeducation, engaging the patient with the mind-body link. Treatment approaches, there are plenty of treatment approaches out there that have got some good research behind them. I've mentioned Laura Goldstein and CBT approach, EMDR. So the Cochrane review is underway. I don't know when that'll be ready, but it is underway. Using that phased approach, so you've got to start at a much lower level, doing some basic engagement work and doing some basic stabilization work to make sure the patient is safe, and working with them on phase one before you jump into phase two, which is the actual psychological therapy type stage. It's really important to do phase one first, otherwise you're working in quite an unsafe way with the patient. So just before I go to questions, we've got a couple of resources. Next slide, please. So this is a really good recent article. It's come out from John Stone, October 2020. I'm mentioning it because I think I spotted a few of the questions that popped up on the paper, on the WhatsApp, sorry, and it actually refers to some of the things that you're talking about. I think somebody said, what questions can you ask, or how can you describe things to the patient? This paper, which I can't actually show you because I'm just a little window, aren't I? So, but it's a very good paper. It's got some really good examples, concrete examples of things that you can say to patients. How you can explain things, how you can explain the fact that it is a positive diagnosis, not one of exclusion. It really is a very comprehensive and very useful paper, and I do recommend that. That's why it's on there, and I don't get any commission for recommending John Stone's paper. Next slide, please. This is something we use in therapy and in assessment as well. It's a booklet that I purchased, and it's by Janina Fisher. It's quite old now. It's 2007, but it's a resource to use in sessions with patients. So it does have the window of tolerance model in there, but it's got all sorts of other resources that you can use. You only use the ones that are relevant to the person that you're talking to, but sometimes it can be helpful to photocopy and laminate something to keep in session, so that you've got that information to help you explain something to a patient. Next slide, please. This is the sensory motor psychotherapy I was talking about. It's a book that goes into that. It's really thick, but it's got a lot of resources in it if you are going to be doing some work with these patients. Next slide, please. Everybody sighs with relief. Jane's finally finished. I'm sorry I ran over.
No, that's great. Thanks a lot for that, Jane. That was, I think, it's really important. I think how you've, you've hammered home how important it is to communicate, how to communicate these things to the patients. I think a lot of us will struggle with that, to try to not to invalidate patients' symptoms.
Yeah.
And I think I'm
Absolutely.
certainly going to look at that John Stone paper. I think
It's
that's
worth it. Yeah.
But I think we are kind of a little bit late, but I think what we'll do, if we are virtual, so people, if they want, they can go off and get a coffee. But I think we might just do questions during the coffee break, if you like, and then just kind of carry on with the meeting. So if you want to get a coffee, that's fine. But also, we'll just do a few questions before the next speaker. So some of the things that are coming up. I don't know if Dr. Burness is still there, or is she?
Hi, yes, I am.
Oh, she is.
Sorry, thanks a lot for taking the time to do this, by the way. So there's a few questions saying, is there any role for any medical treatment, as in with medicines, in functional neurological disorder? Some people are saying valproate, might be something that's useful, or is medications not.
So this has been looked at. There's one small study that shows SSRIs can potentially help with dissociative seizures, but we don't tend to use them unless we're treating something else. There is no pharmacological treatment for FND. Okay. There's nothing licensed for it, and there's nothing with any good evidence for it. I think valproate, particularly considering most of these patients are young women, I would absolutely not give valproate to somebody just because they've got functional symptoms. And again, I think it perpetuates this medical model of you've got something structurally or physically wrong that we have to correct.
Yeah,
it's much more of a therapeutic, psychotherapy and physical therapy where it's appropriate is the way to go, not drugs. Yeah. But it's very important to treat comorbidities. If someone's hugely anxious, that will make their functional symptoms worse. So we should be treating anxiety and treating mood appropriately, but yeah, not primarily for the functional symptoms.
Sure. I mean, do you know, is there a kind of a centre in the north of England which specialises in functional neurology?
Oh, that would be Leeds.
Okay, really?
So we've got around the country. There've been people like Jane and I desperately trying to fight against the financial constraints of the NHS to build services, and there are people who are ahead of us. So I trained in Sheffield with Marcus Roiber, and they have about 9 therapists, psychotherapists treating people primarily with dissociative seizures, but with any functional symptoms. There are, here obviously in Liverpool, we have a small service. In Manchester, they're building a service. They've had a good neuropsychology service for years in Manchester, but they are now starting functional neurology clinics. They've not really had a neurologist who's been interested. It's been very psychology run there. I'm not sure what they've got in Newcastle, but certainly in Edinburgh, that's where John Stone is. There's expertise, but in Glasgow, the neurologist who tried to do it has been shut down, because what happens is inevitably you get long waiting lists, and obviously your bosses don't like that. And then inpatient treatment, there are several units in the country. There's one in Bath, there's a couple in London, and then there is one in Leeds. So the psychological medicine unit in Leeds with Peter Trigwell, they do inpatient treatment for some of these severely disabled functional patients. Right. So they've got real expertise actually, that unit in Leeds. I believe they're rebuilding it. I plan to visit when they do. Okay. So there are places, but the problem is all of the inpatient treatment has at least a 2-year wait, and that's pre-COVID. Most of them won't take referrals at the moment because COVID's made it, so bad that NHS England have said you can't refer at the moment. So that leaves us really stuck, and patient symptoms have worsened a lot.
So I think the mainstay of treatment then is referring to psychology then, really. I mean, do you refer the majority of patients? Who do you decide to refer or not to refer?
So again, it's resource. So community psychology services, and we've had the leader for the sort of IAP service locally to come and talk to our functional MDT. And, he gave us this great presentation about the different levels. There's counselling and CBT, and then there's complex CBT, and functional patients can be treated in the complex tier. But the real experience is the patient goes to those services, they see their seizures or their weakness, they say they're too complex, and it's unusual for them to be helped by standard psychology services, which is a real failing of us as the NHS. So we try, if anyone's anxious, we'll send them to if there's anything like anxiety or mood or something that fits better with the community services, we will try that. There are psychologists, of course, out there in the community who are really good at this, but I think they're few and far between. I think Jane would probably agree with that. Jane, would you?
Yeah, definitely.
Yeah, I mean, Jane, do you have any opinion about who's good person for you and who's not so good to be be seen in your service with these kind of conditions?
Well, we're open to anybody, basically. It doesn't matter how long they've had the condition. It doesn't matter how complex, I suppose. It's the main things we tend to look at when we see patients deciding whether or not they might be suitable for the service is, have they got a firm diagnosis? Do they understand that diagnosis? Can they actually see links between triggers and the onset of symptoms? So all of those kinds of things, and have they actually proactively tried anything themselves that isn't around medicine? So they might have tried doing a bit of mindfulness, or they might have tried doing some sensory grounding, because often Dr. Burness, when she first sees them, will mention things like sensory grounding. And sometimes when I see the patient, they've actually taken that and really tried it and had a go at it and found it helped in certain ways. So we're looking at kind of factors that might predict a good engagement in therapy, because at least if we know somebody's going to engage in therapy, they've got a much better chance than somebody who's sitting there thinking that it's not in my head, it's not psychological. I think I was bitten by a tick and I've got Lyme disease and nobody's listening to me. They need to have whatever tests need to be done to resolve that question in their heads. And then later on they can come back to our service, and at that point they may be ready to go forward to therapy, but they're not going to engage in psychological therapy unless they are fully on board with the diagnosis. So that's the approach we take in selecting our patients, but we don't select them on the basis of complexity or how long they've had the condition or any of those other factors.
So we look for insight and motivation. Absolutely. I think that's in 2 words.
Yeah.
If they say there's no way about F&D, it's a complete waste of time.
Yeah.
And if they're not motivated, so as Jane says, if they show, they just sit there saying, I'm not going to do anything about this. And if they get, it's a bit like rehab, isn't it? There's just no point. Probably like the pain management programs as well. Absolutely. If they're not going to engage and work at it themselves, it's
if they think they need further investigation and they're not going to want to engage with it, are they? No,
yeah.
Okay.
So people will say, we'll say, Jane and I do a joint clinic, and we'll say, what do you think you need? And if the patient says, I need another MRI, well, then there's no point. You can't go any further with psychology at that point.
Yeah. One question here is, do kind of adverse childhood events, like abuse and things, are they associated with FND?
They are risk factors. Sorry, Chrissy, did you want to take that one?
I can do. So I think I touched on that. So yes.
Yeah.
Childhood. So I think I talked about this a bit. So predisposing factors can include early life experience, and that can include abuse, but actually commonly it includes neglect. So it doesn't have to be anything overtly traumatic that's happened. It can be a learned pattern of behaviour or experience. But yes, certainly having had any form of psychological or physical trauma is a predisposing factor and puts you at higher risk of developing functional symptoms.
Could I just reinforce what Chrissy's just said, that it is a risk factor, it's not diagnostic. And that is something that we always need to hammer home to people, really, around the fact that there is no digging around for trauma. It's something that people have in the community that don't develop functional disorders. Sure. It's prevalent in the community. But it's not diagnostic. Sure.
Well,
and that's, sorry, I'm going to say something else as well. So what's really important, I think, when we talk to patients is, if we say, I suspect that you've got functional symptoms. Have you ever been sexually abused? Which you might laugh, but some people have done. Maybe, I hope less now, but I've seen people do that in my career. And then the patient just thinks, how offensive, how awful. And some people have even said, what was your childhood like? What were your parents like? Have you ever been sexually abused? Then people are just affronted. If they've never had that experience, they're never going to engage with the diagnosis. So we have to be really careful how we present it. So you don't have to have had abuse or anything like that to have FND. But if you have had abuse, you'll be at slightly higher risk of, well, probably significantly higher risk of developing FND. That's the way to think of it.
I think thanks a lot for that. And I think it's been really appreciated by the delegates and lots of positive comments. So thanks a lot for that. That's really great.
Thank you.
Yeah.
Thank you for inviting us.
Thank you.
Sorry, we can't join the whole day. I'm in clinic, sadly.
That's all right. Well, enjoy the rest of your day.
Bye.
John, can I just ask one question? Is there any difference between developed and developing countries in the incidence?
Oh, sorry. Yes, that was an interesting question that I wanted to ask, actually. Yeah.
So it's a good question. I don't know. I think prevalence figures for FND are pretty poor anyway. is the truth. The figures that we have that are most reliable are from things like inpatient EEG investigation, which obviously many developing countries don't have much of. I've got a colleague who works in India actually, and we spoke about this recently. I think if you look in the literature, there are reports from around the world. I think this is it's a problem we see globally. It's called something different sometimes because of cultural beliefs and expectations, and also because of it's the way that, it's the proportion of people who get to see a specialist or a doctor in hospital. It's the tests that are done, and it's the way it's framed, isn't it? It's the way it's viewed. But certainly within India, within the hospital, it's a neuroscience unit that my colleague works on. It's a really common problem. And she says, interestingly, she feels anecdotally, she sees a lot more men really struggling with functional symptoms there than we do as a proportion. So she feels like almost 3/4 are. So it is something, I think it's something that needs looking at more, but this is a global problem, and it's an age-old problem. So one of the great videos, if we'd had a longer talk, that I have is the shell shock World War soldiers who came back with functional gait disorders and functional speech disorders. And some of them had functional blindness. They'd seen things that no one should ever see, and then their brain just went, whoa, I'm not going to see anything again. And that was all functional. It was called something different. It's called shell shock. But it's the same thing in whichever country or whichever era. It's just how we describe it has changed.
Yeah, it's a global problem. Okay.
I think so.
Thanks a lot. Thank you very much.
Bye.
Bye-bye. So, Nick, would you like to take over? If that's all right. For the.
I would. Thanks. Thanks, John. Can you hear me? Okay.
I can hear you fine.
Lovely. Okay. Thank you very much. Good morning. My name is Nick Plunkett, and it is my distinct pleasure to chair the next session. So we've got three very interesting and diverse talks, I have to say. And I'd like to start by introducing Dr. Deepak Ravindran, who is a consultant in Royal Berkshire Hospital in Reading. Dr. Ravindran is, I think, uniquely placed to give the next talk, which actually follows on quite nicely from the prior talk. And it's in relation to pain services and their response to the COVID-19 pandemic. And it's highly topical, of course, that we include some mention of the COVID-19 pandemic. So Dr. Ravindran is an author and a podcast, delivers podcasts, and has certification and experience in multiple areas of pain medicine and related areas, including lifestyle medicine. And I anticipate a very interesting and thought-provoking talk on how those factors interact in terms of our patients, who I think will be struggling more as a result of COVID and COVID-related issues. So without any further ado, can I invite you, Deepak, to give your talk?
Fantastic. Right, if all of you can hear me, good morning and good afternoon, good evening to whichever part of the globe you're from. Thank you to the North England Pain Group and for the Pain Relief Foundation and Nick for having me on this morning. So I'm just going to share my screen. Nick, just let me know when you can see the screen. Just a minute there.